Hi, my name is Linda Sezik, and I'm a nephrologist at Duke University and president of the National Kidney Foundation. This series is titled 5 Minutes a Day May Keep Dialysis Away, Your Mini Renal Fellowship. Our goal with this series is to provide you with 5 minutes of information about a variety of topics in the care of kidney disease. The first is the who cares part. Why should we worry about kidney disease? So let's ask the question, why should we test for kidney function? The answer is provided in this analysis by Rob Foley, published in Kidney International in 2011. In this analysis, he examined a large population of U.S. adults and ranked those factors that were best associated with mortality. At the top of the list, not surprisingly, was age. But second and fourth were estimated glomerular filtration rate and urinary albumin to creatinine ratio. They were among the strongest predictors of mortality. For those physicians that routinely and regularly test LDL, please note that while it is an important predictor, it is listed here as number 11, and glomerular filtration rate and albumin to creatinine ratio, of which you will hear a lot more about during this series, ranked significantly higher. Let's ask the question another way. What is the utility of measuring serum creatinine and estimating glomerular filtration rate? And what is the utility of looking at the urine for the presence of albumin or larger amounts of protein? This study by Alan Collins presents the very sobering fact that the patient with chronic kidney disease is more likely to die than they are to live long enough to progress to dialysis. This study, coupled with the data seen on the previous slide, really demonstrate that the presence of early kidney disease, as depicted by abnormalities in the urine or only slight elevations in serum creatinine, should be detected in all patients so that adequate cardiovascular risk factor reduction can be employed. So with that first bullet point in mind, that while urinary albumin excretion and estimated glomerular filtration rate are both fabulous markers of kidney function, they are equally as fabulous markers of cardiovascular risk. With that bullet point in mind, we need to establish thresholds. When do you start to worry? At what point is a slightly abnormal value just abnormal enough to justify intervention? Well, this particular slide looks at the sensitivity and specificity of each of these markers along the wide range of its values, giving you a sense for when sensitivity and specificity are both maximized. And you can see that the point at which you will catch the majority of your patients at risk, while minimizing including patients that are not at risk, is much higher than you would expect for eGFR and much lower than you would expect for urinary albumin to creatinine ratio. The values given here are an estimated glomerular filtration rate of about 90 or below and a urinary albumin to creatinine ratio of about 10 or above. Much higher and much lower than you would normally expect. As we go through this series, we'll cover a number of topics. These topics will include how do you screen. Very briefly, we will talk in depth about the limitations of serum creatinine and the various formulae that we use in nephrology to convert creatinine to creatinine clearance or estimated glomerular filtration rate. We will also talk about how to interpret the urinalysis, using all of the nephrologist tricks about how each of the little pads on that urinalysis dipstick can provide you with tremendous information. Suffice it to say, at the high level though, while you're looking at the urinalysis, the most important little pad is probably that for proteinuria. If someone is proteinuria positive on dipstick, then they've got significant urine protein excretion, and your next step should probably be to measure a urine protein to creatinine ratio. But when someone is trace or negative on dipstick, They still could have elevated amounts of albumin in their urine. And these are the people that we've been talking about in the previous slides as being at the highest cardiovascular risk. Additionally, these will be the largest proportion of your population that you screen, those that will be dipstick negative but will still have albumin present in their urine. And in those patients, you would definitely want to go ahead and get an albumin to creatinine ratio. In an ideal world with unlimited resources, we would want to screen all patients for the presence of urinary abnormalities or decrements in their glomerular filtration rate. But we do not live in that ideal world, so we need to focus on those patients who would be at highest risk for the presence of kidney disease. That would include those patients with diabetes mellitus, hypertension, chronic infections like HIV and hepatitis C, as well as autoimmune diseases, and the use of medications that are associated with renal toxicities, such as nonsteroidal anti-inflammatory agents. Of note, very exciting findings have recently been published in nephrology, demonstrating that certain genes may link a higher risk of kidney disease within families, particularly within the African American community. So I would like to add to this list of people who are at highest risk for kidney disease and those who definitely need to be screened, anyone who has a relative on dialysis. So thank you so much for watching what will be the first of a many-part series. The next slide will give you a list of the topics that we will cover over the upcoming months. Please do not hesitate to give us your comments, because these slides are motivated out of the desire to provide you with easy to assimilate information to help you take care of your patients. So on behalf of Medscape and the National Kidney Foundation, my name is Linda Sezek, and I'd like to thank you so much for your kind attention. Please give us your comments, please seek out information on kidney disease, and please let us be your source.